Hi everyone, Professor Isaacs here, and today I'm going to be taking you through the lesson of a nurse's role in a code situation. So a little bit about me. I have over a decade of experience in emergency nursing and trauma. I'm board certified in both emergency medicine and trauma nursing. I have my master's in nursing education, and I'm currently pursuing my doctorate in nursing education at Columbia University. While I will be your lead instructor today, I have enlisted the help of some of my trusted colleagues, whom you'll meet in just a minute. Now, just a few moments to get ready. That's a little better. So first we need to determine what a code is. Different facilities use different terminologies for a code. Code blue, code black, code rainbow, it really doesn't matter. But generally, the terminology is used to announce that there's a patient who needs immediate life-saving interventions and requires the code team to appear at the bedside immediately. So what I'd like to do today is discuss the nurse's role in a code situation, as well as all of the members of a traditional code team and what their roles and responsibilities would be. I don't think we'll actually have time to observe a mock code today, but I can assure you that we will save that for a future lesson. Now, I like to be as interactive with these presentations as possible, so I will be asking a few questions, and you can feel free to type in your answers or call out, although I don't think I'm going to hear you. There is no wrong answer. We have these discussions because I want to get your opinions and your thoughts on the questions. So the first question is, what do you guys think are the roles and responsibilities of the nurse in the code situation? I'll wait. Okay, so those are all good thoughts, and we're going to take a minute to go over them. I will say, though, that some of the comments do go outside of the scope of practice of nursing, and even though, yes, this may be an emergency and they may be ICU nurses, things like intubation and central lines, those are skills that are reserved for physician level or for intubation, in the case of intubation, respiratory techs would be able to do that. So while the code team does do a lot and the nurses do a lot in a code situation, we still do have to stay within our scope of practice. So our next question has to deal with the person who leads the team. Now, do you think there's any situation, any code situation in which the nurse could serve as the team leader? And feel free to answer. Okay. Right, so if the nurse is the senior level provider in the room, then guess what? They're in charge, and they will stay in charge until they are relieved by a higher level provider, be that a PA, an NP, and hopefully, in a good code, eventually the physician. So basically the nurse is gonna run the show until someone else does. Now, I'd like to take a minute to talk to you guys about what makes up a good code team. And to do that today, I have enlisted the help of some of my trusted colleagues from the world-renowned and very prestigious Legoland Medical Center. So, Nurse Val, are you with us?
Hey there, Professor. How are you today?
I'm great, Val. Thank you so much for helping us out today.
It's my pleasure. We have been looking forward to this all week.
It's great to hear. So, is the team in place?
We're all here and ready to rock. Just putting some equipment in place.
So let's talk about the nurses first. Ideally, in a code situation, you want to have a minimum of 2 nurses, one on each side of the bed. Whether it's the left side or the right side, doesn't matter, but each has a very specific task. One is usually doing medications, getting IV access, And on the other side, that nurse is usually going to assist with procedures with the physician, monitoring vital signs, and any other tasks that may not be necessary. They can also do IV access and such, but you really want to have a nurse on either side of the bed. Now, you're going to need someone to get the medications for the nurse to administer. Hopefully that could be sometimes a nurse at the crash cart, and that person's going to be responsible for pulling all the meds and basically handing them off to the medication nurse who's giving the medications. If you don't have a third nurse, sometimes you can get a pharmacist who's a member of the code team to assist with medications and hand them off to the bedside nurses. The advantage of having a pharmacist is, number one, that they know all the medications. They're the experts in meds, obviously. And secondly, they're usually the ones who put together the crash carts, so there's never any confusion for them about where anything is, which is kind of nice. So now that we know who's on either side of the bed, we're going to go to the head of the bed, and that person is going to be in charge of airway. That is their sole responsibility. Now, this can be an ED physician, a surgeon, sometimes an anesthesiologist. In some facilities, it can even be a member of the respiratory team. I would check with your own institution to find out who can do intubations and who can control airways, and that way you know who it is. Either way, that person at the head of the bed's sole responsibility is to make sure that the patient is getting the oxygen they need. At the foot of the bed, traditionally, is your team leader. Not that kind of team leader. This is the person who's going to control the situation. They're going to order medications, call in necessary procedures. They really should be the one voice heard above all else. And when they speak, everyone needs to listen. This is usually the senior-most provider on the team. Only the team leader decides when the code ends or calls the code. So in every code, you need to have a recorder or somebody who's documenting. This is somebody who writes down everything. When meds are given, when procedures are done, they keep time, they monitor vital signs, they're keeping an eye on the monitor, the patient. They have to be meticulous about everything. You know, we all know the old adage of if it wasn't documented, it wasn't done, and that is so important in a code because things are happening so quickly. You know, this isn't a situation where the doc writes an order and you pick up the order and you follow the order. No, this is stuff is getting called out and screamed out and yelled out, and it's chaotic, and somebody has to be on top of everything that's been done. And this can be, you know, it could be a nurse, could be a nurse manager. Very often it's a nursing supervisor who's on duty. Whoever's documenting, they don't do anything else. They don't run for supplies. They don't assist in patient care. Their job is documentation, period. We can also have some ancillary staff in the room, like these guys. Now, these could be PCAs, whatever your facility calls them, PCAs, nurses' aides. They're ancillary staff. They are there to do chest compressions, to pull things off the shelves, to grab supplies, to run for blood if it's needed, to get something that's not in the room. They are a vital part of the code, and if you can have them, great. You just don't want to have too many, and you want to make sure that each person in the room is doing a job. And to that point, I put another question to the group. Is it possible to have either too many or too few people on your code team? So I'll admit this was a little bit of a trick question because both answers are right. It is very easy to have too many people in the room during a code. You may think that the more help, the better. This usually isn't the case, especially when your team leader needs to be heard and communication needs to be concise and efficient within your code team. If you have more people in the room, this can actually become problematic. It's not uncommon for the team leader or whoever's kind of running the situation to say, look, if you're not directly treating this patient, please wait outside the room. And there's nothing wrong with that. On the other hand, you can't really run a code on your own. You can do CPR, but it's really hard to establish an airway and grab the meds from the cart and do everything that needs to be done in the code. You need the team members from the other disciplines to provide those life-saving treatments that this patient's going to need. At this point, I would love to run through a mock code with you guys. In this simulation, we would have each nurse kind of rotate through the positions that the nurses perform: bedside, crash cart, recorder. I want to make sure that each student experiences all the tasks that are asked of the nurse. Unfortunately, as we're pressed for time today, we're going to have to save that for the next session.
Aww.
I know, Val, but we can only do so much today. I do want to thank you and your team so much for helping us out today.
Anytime, Professor, and good luck to all your students. We know you'll do great with such an amazing teacher like yourself. Okay, guys, let's head to our next code.
So after we had run through some of the mock codes and simulations, we would take some time to debrief on them. In our simulation labs, we're very lucky to have video recording capabilities. So after the codes, we can actually go into the lab, view the simulations, and discuss where the strengths were and where there may be room for improvement. We would also, after, do a quick multiple choice quiz, and come on, you knew you were going to be tested on this, let's be honest. We would also do some minute papers and some chain notes just to kind of see how the lessons went. Once that was done, we would then hand out a Likert based evaluation to see if the teaching was effective. So I just want to thank you all for watching today. And of course I want to thank Val and her cohorts at Legoland Medical Center for helping us out. And I know that we all want to wish you guys the best of luck as you continue nursing school. And I hope that you'll join us for our next session. Take care.